Nobody asked anything there, but I do have a request, and it was to talk about the spinal cord. So the first part of this discussion is going to be a little dry maybe, but it's important because if you understand how the spinal cord works, when we discuss the injuries, it's going to make a lot more sense. You'll be able to put the pieces together. Just like with all of the things I like to talk about, if you understand the why behind things and you understand how things work, when we start putting issues and putting problems in with a normal working system, we have to fix that. And it will be easier to understand how to fix it if you understand what normal is and what the problem affects the normal with. So let's get started. Turn on my Wacom pad. We're connected. Okay. The spinal cord. I found this cool picture and I liked this cutout thing here. I thought it was really cool. Oh, I didn't mean to do that. Let's erase that. I thought it was a laser pointer. It's because I have it red. Okay. Let me get the laser pointer out. So yeah, I like this jagged. I thought it made it look rugged, strong, or cool, like Rambo or something. Rambo. Okay, so the spinal cord. What are we going to discuss with this spinal cord? Well, we're going to talk about the anatomy. Like I said, this is going to be more of the drier part, the anatomy and how it works, just because it is super complex. Our nervous system is super interesting if you are into the nervous system and you really like neurology. But it is complex, so if you're not really interested in it, it might sound dry, but we're going to make it exciting with stories. We're going to talk about reflexes. That's an important thing, and I have some stories that go along with that. We'll talk about injuries to the spinal cord and to nerves. It's important to talk about injuries because no matter what area you work in, you will come across a patient who has either had a fresh spinal cord injury, surgery due to a spinal cord issue, or you will deal with someone who has an old injury or old surgery. So it's very important, and it crosses all nursing fields. We won't talk about infection. I forgot to take that out of there. So scratch that. The infection that I was thinking about was meningitis, but that's an infection of the meninges, which include the brain and the spinal column, the spinal cord. It's the lining, and we'll talk about that another day. Okay, I like this picture. I found it, and this is cross sections of the spinal cord at the different areas. So this here, the cervical, that's your neck. Well, that's not your neck. My drawing is wonky. Oh, that's a highlighter. Okay, well anyway, it's not the neck. The cervical spinal cord is in your neck area. And then your thoracic is your chest area, and then you've got your lumbar, which is your lower back, and then your sacral, which is below lumbar, like in your butt area. Okay, so I thought that was cool, how everything kind of changes as you go down. I don't know, I thought it was cool. All right. Purpose and anatomy. It's actually going to be anatomy and purpose, but let's talk about this. I covered up some of it. That's why you'll see these lines here. It's because we don't need to talk about all the anatomy of it in such detail. So I covered up this just because it's it's a lot of noise if I don't cover it up. And we're not going to really discuss those things. Okay, so the purpose of the spinal cord is it's basically the nerve highway. So you want to think about it as either, if you're into cars, a highway with cars, a railroad tracks with speed trains. It's a way for information to get from our fingers and toes to our brain and back. So when things go wrong with it, it means that the communication is cut off. The trains can't go anywhere. There's a roadblock up. So it's important to remember, no matter what, the spinal cord is the highway for nerves. It also has the reflex arch. Now, sometimes our body is in danger and it wants to fix that danger, wants to take us out of that dangerous situation before we send a message to the brain and bring it back. So we'll talk about the reflex arch a little bit. And then if you look at it, it has this H shape, right? Here's the cross beam and then the other side. So the H shape is the gray matter, and then outside that gray matter is white matter. And it gets called different things. It can be called column, but for the most part, I know it as gray matter and white matter. In anatomy class, I had this, it was an adjunct professor, and he would always talk about the gray matter. It doesn't matter what we were supposed to be talking about, he would go back and talk about this cross section here, talk about the gray matter and the white matter. I can't even remember. It was not a great class because he would teach about the gray matter, teach about the white matter. Then when it became time to take a test, it was a 3-hour class. He would give us an hour to study the material. It was nothing he covered in class. He just gave us a list of things to study. And then he gave us the test. It was a handwritten test by him. And he had the question, and then he had the answers. But the answers weren't linear like this. They were one after another. So it would be like A, B, C, and then D would be on the next page. It was a miserable class. Everything I learned about anatomy, I learned in physiology, because in my university it was 2 separate classes. Okay, well, I didn't mean to do that. Let's go to the next slide. Okay, and then we're going to talk about nerve roots, because those right here, those are also important, especially here, the ganglion root. We'll talk more about that on the next slide. Okay, so what do they all do? Each one has an importance. So we'll talk about the dorsal horn first. And the dorsal horn is, think about dorsal, the dorsal fin on a dolphin. So it's the back. So this is the back side of the spinal cord here. And then what they mean by horn is each side of the H line. So you got the dorsal horns, left and right, and then you've got the anterior horns, the left and right anterior horns. And they get called different things. Sometimes, I forget what I read online, but there's just different names for the anterior versus the dorsal. But for the purpose of what we're talking about now, we'll use the words dorsal and anterior. Okay. I'm going to leave this picture up just because it's going to tell us what we're talking about. So the dorsal horn, this is where it's important to pay attention, because when we start talking about spinal cord injuries, we need to remember which path goes which way. So the dorsal horn is ascending. So anything that's coming from the body going up to the brain, it's information from your fingers and toes going up to your brain, and our brain has to decipher what happened or what's going on. So if you think about it, what information do we have coming from our peripheral areas going to our brain? Well, sensory, right? That includes pressure, vibration, how something feels, if it's soft or hard. So anything sensory, whether it's coming from our peripheral or our organs, so visceral means organ here. Visceral, like stomach pain, appendix pain, that is going to also go up the ascending tracks. So ascending, going to the brain, sensory. So the anterior horn, the front part of the spinal column or spinal cord. This is our descending tracks. So what does the descending is? What does the descending do? So you've got signals in your brain and it's telling your peripheral to do something. These are your doing tracks. So you want to walk, so your brain sends a message down the anterior horn out to your muscles and it tells you to do whatever, walk, run, crawl. So your descending tracks are impulses telling your body what to do. So, and this includes the muscles and your organs, right? Because they both have motor neurons. It's easy to think about your muscles in your arms and legs making movements, right? But your organs also have muscles and they also have glands, and this is the signal tracks, that descending the signal tracks to tell your organs when to contract, like your stomach and your heart. All that is visceral. Okay, ganglion. So how do we think about the ganglion? The ganglion is like our train stop. If you think about a train stop in a major city hub, there's a lot of trains coming in all at once. And people get on it and then they go out to their different areas. So ganglion, this little lump right here, this is where a bunch of neural cells, nerve cells, neuron cells sit, and they wait for signals to get to them, and they get all excitable, and then they either pass it this way or they send something back to the body. So when you have reflexes, this often stems from here, this area here. So touch is part of this, pressure is part of this, and vibration. And then you got your somatic and visceral. Visceral we talked about as organs, somatic is your muscles. A lot of times, I didn't put this in this lesson or session, but a lot of times people can form cysts because ganglion cells are not only near the spinal column, you can even have them in your hands or wrist. And like I said, it's just a bunch of nerve cells. And sometimes you can form a cyst on there, and there's a nickname for that cyst, and it's called a Bible cyst because there's an old folk remedy for it that you can just smash it with a Bible, because usually Bibles are the heaviest book around unless you have a really big dictionary. But you can smash it with a Bible and you can pop it open and it, for a little bit, will go away. If somebody talks about doing that method, you really should encourage them to stop it, because you can cause infection. You can also, it's going to come back. It's going to come back if you try and explode it by smashing it. But you can cause injury to your soft tissue. You can even cause injury to your bones and ligaments and everything. So just don't smash it. If it's really bothersome, it's usually not painful, but if it's really bothersome, just go to a doctor and they'll actually remove the cyst to prevent it from coming back. because if you smash it, it'll come back. It's just draining it, basically. Also, don't drain it yourself. Don't poke it with a needle or anything, because you're just going to cause more of a risk for infection. Yeah, in nursing school, I had a fellow student, and she says that she would take a textbook and smash hers all the time. And I was like, oh, that's pretty gnarly that you would do that when you could just get it removed, or just not, if it's not bothersome, just leave it be. Don't really understand that. Okay, so the peripheral nervous system. What is included in that? Well, we have the cranial nerves, and then we have the spinal nerves. And the spinal nerves are the nerves that come from your spinal column or your spinal cord, and it goes out to your peripheral, and it spreads out, and there's a whole bunch. If you ever get an opportunity, there is a museum exhibit, and it's usually at science museums, and it's called Body Worlds. And what they do is, often at these exhibits, is they preserve bodies through plastication, and they have the two that I went to, they have a display for the spinal column, and it'll go out to all the nerves. And it's really interesting because you can see where it originates, and it's just like the textbook, and then it goes out and you can see all the little nerve endings and everything. It's very interesting. So if you have an opportunity, I highly suggest that you check that out. All right, so spinal nerves. We're going to save cranial nerves for the next slide. There are 31 spinal nerves, and they are named after the vertebra below its exit. So the nerve is here, here's the vertebra, and this nerve is named after this. And it coordinates with dermatomes. So each spinal nerve and its branches all the way out originate in the certain area of the spinal column, but that branch out is a dermatome for that one spinal nerve. And I'll show you that in a second. It is responsible for reflexes, because if you think about it, if you touch something, let's say you have a hot pot and you touch the hot pot, your peripheral nerves are going to send a signal back to your spinal column, and your spinal column is going to send a message back to say move. It's not, you're not going to even have to think to move. Your hand is just going to move away. So your spinal nerves are responsible for reflexes. So here's dermatomes, and it's important to know this because if your patient has lost motor skills after a certain dermatome, then you can figure out where the injury is on your spinal cord. Or if your patient is moving fine, but they have lost feeling in a certain area, then that will also tell you where the injury might be located. So, how do you test these? You use something sharp. A lot of times in a neuro unit, the doctors will have a little pin, but you really don't need something sharp like a pin. You can take the back of a Q-tip. In the hospitals, we have those wooden Q-tip sticks. You can use that. When I worked in the PACU, we had to test the dermatomes after patients had back surgery, and we just broke a tongue depressor popsicle stick like in half, and then that sharp edge there is what we used. But right now, when I'm nursing and I have to test a dermatome, like the level of the feeling or the level of movement then I will use the back of a wooden Q-tip. Sorry, I have a tickle in my throat. Okay. One thing before I move on to the next slide, I want to talk about reflexes. So reflexes occur in the spinal cord area. It does not occur in the brain. And it's very important to know that and to recognize that. One of the patients that I had it was a very, very difficult case. The patient had brain death on a certain day, but he was on a ventilator. He was, for all intents and purposes, it just looked like he was sleeping. He was on maximum life support, so that means that we're supporting his blood pressure, we're supporting his heart, we're supporting his breathing. But during a brain flow study, there was no brain flow to the head, which means that he had brain death. In today's modern medicine, a lot of times you can have brain death, but not cardiac death. So the patient is declared, it's complicated, but the patient is declared dead. But in this case, the family member wanted the rest of the family who was out of state to come in to say goodbye before we took the ventilator off, which is fine for a couple days. So the provider asked the family member, can you tell them to get here by a certain day? So the family came in on that certain day, and it was a very rough time for this family. This patient was very young. It was a very traumatic incident. It was a very sudden situation. So everyone was in a lot of grief, a lot of stress, and they didn't want to take the breathing tube away. They felt that the patient was that he was going to wake up out of this coma. And they couldn't understand that the patient was not going to come out of the coma because his brain was already dead. It was done. There was no blood flow at all. And it was a very difficult process. It took about 2 or 3 days. I can't remember right off. But the patient was decompensating fast because he didn't have any way for his body to regulate itself because he had brain death. And even though his brain was dead, he still had his reflexes. So when the family did decide to withdraw the ventilator, to take the ventilator away, to turn off the blood pressure medications and let the patient pass peacefully to cardiac death, the patient started to move his arms up. And even though we explained to the family beforehand that even after the patient passes away, or as the patient is passing away, those reflexes may occur. And it looks like the patient is moving, that the patient is waking up, but those are reflexes that will occur even though the patient is dying. So they couldn't understand that those reflexes were in the spinal column and not in the brain. They weren't the patient doing those movements. It was his body automatically doing it because we all have the reflexes. So he started to move his arms up, and they were really excited about that, and I had to tell them these are the reflexes we were talking about. It's not him moving. Those are the reflexes. And it was a very sad time, but it's very important that you explain to your family members before you go through a process of a patient dying, whether you're on the ICU, ER, or on a med-surg floor or acute care floor, that you explain to the family what to expect when their loved one is going to pass away. We did the best we could in explaining for this family. Again, it was a very traumatic time. I think that it helped because in the moment when I was able to say, those are the reflexes we were talking about, then they were able to let it go. Whereas if I didn't explain it, or the providers didn't explain it, it'd be something that they would fixate on and try to get us to put them back on life support. So make sure that you explain to your family members what to expect in death, everything, and it'll help the family be at ease when they see certain things happen, because it can be scary. Dying can be scary, especially when we don't know what to expect. Also, before you bring a family member into a room, let them know what to expect. A lot of times, if you just bring them into the room, or they walk into the room and their family member is intubated, or they've got all these wounds all over, that might be the first time that they're seeing them. Even after surgery, they've got all these drains coming out of them. It's very scary for someone who's not in medicine. So all these drains may just be a normal thing for whatever surgery that patient had, and it's no big deal, but to them it's scary because those drains are filling up with pink stuff that looks like blood. It's scary. So make sure you let your family members know what to expect when they walk into the room. It builds trust in you, because they know that you are taking care of them as well as their loved one. All right. Let's talk about cranial nerves now. So the cranial nerves mainly affect your shoulders on up. I'm going to pull my pen out because I'm going to show you an easy way to remember your cranial nerves. All right. Cranial nerve 1, and they are all labeled with Roman numerals. I don't know why. I guess it's easier that way. But let me get to the location here in my book. It's a lot easier to remember it this way. All right. So you got your cranial nerve 1, and that's going to deal with your nose. Olfactory means smelling. So you've got number 1. So we're going to draw a number 1 for our patient's nose. I can do a better one, I promise. This is how I remembered it in nursing school. And once you do remember it, and you draw it out a couple times, and you think through it, you'll be able to understand it better. Okay. So, olfactory, that is your nose. Sense of smell. 1. All right, cranial nerve number 2, that is vision. So that's your optic nerve, and that's number 2. So here's our eyeballs, and this will control your vision. So if you're unable to see anything, it might be an injury to your optic nerve, or it might be swelling that's pressing on that optic nerve. 3, 4, and 6. These all control the motions of your eyes. So 3 is the upward movement and the raising of your eyebrows, and then 4 is looking down, and then 6 is looking side to side. So 3, in my brain, this went a lot smoother. Okay, 3, and then we've got 4 down here. It's gonna look like a very scary man, and then we got 6. Shunk, shunk. All right, we skipped 5. That's because 5 is an ocular motor. Trigeminal, that is the nerve, and that controls your facial expressions. I want to be able to tell you, right? So like some of your, I'm sorry, not facial expressions, your chewing, corneal reflexes come from 5, and then your scalp sensations, and also forehead, scalp sensations. So 5 kind of encompasses everything. So if we look here, we're going to make 5. Looks like a man. Here's his mouth, right? Okay. 6 we already talked about. 7. Where's 7? 7 is the one that does facial expressions. So 7. Whoop. Don't mind my drawing. That's our facial expressions, right? Controls your smiling, your forehead raising, all that. 8. 8 is the acoustic nerve. So let's draw our little ears here. And that deals with our hearing. It also deals with balance, because if you think about it, your inner ear helps with your balance. All right, 9. That's your glossal pharyngeal. So let's draw a tongue here. That's a tongue. Want to clarify, it's a tongue. And 9, glossal pharyngeal. So that's going to deal with salivating. It's going to deal with swallowing. And then it's also going to deal with some of your taste. So we're going to put 9. Okay. 10 is vagal, your vagus nerve. And that deals with your swallowing, your gag reflex, talking, sensations of the throat and larynx, the abdominal viscera. So when you vagal down, that's the nerve you're stimulating. So a lot of people put 10 here. What I like to do is make a necklace too, so that you remember that it deals with abdominal viscera. See, he's got a chain with a 10 on it. It says 10 chain. Okay, and then 11 is your shoulders. So when you shrug your shoulders, you're activating cranial nerve 11. Accessory muscles. So draw some shoulders here. And then 12, the very last one, is the hypoglossal. So this deals with taste as well, and also movement. So 12. 12 deals with movement. So I encourage you, when you're studying your cranial nerves, if you go into a neuroscience type unit or a stroke unit, you're going to be testing these a lot. So the first few times you do it, you may want to draw out your face or just have it drawn out so that you know. But 1 is nose, 2 is vision, 3 is upward movement, 4 is downward movement, 6 is side to side movement of your eyes, 5 is sensations, your trigeminal nerve and chewing, 7 is facial expressions, 8 is hearing, 9 salivating and swallowing, 10 is gag, swallow, and then your abdominal viscera, your vagus nerve. 11 is your shoulders, shrugging, and then 12 is movement. Okay. Sound good? Sound good. Very good. All right, so talked about the peripheral nervous system. Now we're going to talk about the autonomic nervous system. So we got 2 parts of this nervous system. We've got the sympathetic nervous system, and we've got the parasympathetic nervous system. This might be your The sympathetic is your fight or flight, and this one is your rest and digest. That's how you can remember it. And I have pictures on the next slide to help us remember it even more. So, fight or flight, rest and digest. My favorite one is the parasympathetic because I like to rest and digest. But I probably activate my sympathetic nervous system more than I would like. So these both work on your organs and glands, so that's important. Okay, so sympathetic nervous system, we're going to go through what they do for the organs and glands. So they're going to start to vasoconstrict. We're going to elevate your blood pressure. We're going to enhance blood flow to the skeletal muscles because remember, this is fight or flight. Don't know what's going to happen. We gotta be ready. We're going to increase our heart rate and contractility to make sure that we're getting blood to those skeletal muscles. We're going to increase our respiratory rate so that we can make sure that oxygen is going on the blood that we're getting to our muscles. We're going to have smooth muscle relaxation of the bronchioles so that we can take in air without any restrictions, the GI tract and the urinary tract, the smooth muscles. But our sphincters are going to, constrict up because we don't want to pee and poop when we're trying to run. And then we dilate our pupils so we can take in more. We can take in more about our surroundings. And then increase sweat gland secretion because we want to stay cool while we're fighting or fleeing. And then reduce pancreatic secretions because we're not digesting. It's going to reduce because we're not really putting a lot of blood flow to the pancreas because we don't really need it. Let's talk about the parasympathetic. Super chill. We reduce our heart rate. We reduce the contractility. We reduce the conduction and velocity. Because the conduction velocity, which is the electrical activity of your heart. Because we're chill. We don't need to worry about anything. We're resting. Our bronchial smooth muscles constrict, not tighten up real bad, but it constricts so that it's normal. We don't need to take in a lot of air. We're just chilling. Our GI tract tone and our peristalsis starts working again because we're just resting and digesting. Our bladder gets more tone so we feel like we need to pee and we can go ahead and pee because all of our sphincters are relaxed. You're not going to pee yourself, but they relax enough to where you can actually pee and poop if you needed to. And then this one is part of the parasympathetic, the vasodilation of external genitalia. So like the swelling of the clitoris and then also erections is due to the parasympathetic. And that's going to make more sense on the next slide with my picture. It's not a picture of an erection, I promise. You can stay on the line. Pupil constriction, because we don't really need to see and be aware of our surroundings because we're just chilling. There's nothing going to happen. And then everything starts working. So our tear ducts are working, our salivary glands are working, our pancreatic secretions are going on because we are resting and digesting, and we need these to digest, the pancreatic and salivary glands. All right, so sympathetic is being chased by a bear. Your sympathetic nervous system, everything that needs to happen to be a successful runaway from a bear, your sympathetic nervous system is who you need to engage. Your sympathetic nervous system is what's going to be working when you're running from a bear. If you're having a nice, relaxing, romantic meal on a beach, hearing the waves crashing at dusk with the person you love, then that's your parasympathetic because you're eating, and I'm hoping it's good food because this looks like it's a very expensive setup, and you're going to sit in these chairs and hear this, and it's super relaxed and chill, and yeah, That's your parasympathetic. Unless you're popping a question like, will you marry me? Then you might have some of your sympathetic going on. But imagine this scene here by the beach is one that you're not going to pop a question at. Hey, you could even be alone sitting in one of these chairs and just not have anyone sit in the other chair. That would also be relaxing. All right, good deal. So, pupillary change. This is very important because you can tell a lot from a pupil change. So normal pupils, they'll probably be, depending on the person, it's different for everyone. Might be a 2 to 4. Some people have really large pupils and you might consider it a 5. And there's tools out there. They have it on, if you buy a medical flashlight, little medical flashlight, it'll have the pupil sizes on there so you can kind of compare with that. If you've been doing a lot, you can kind of say, okay, yeah, that looks like a 2, that looks like a 3. It's also important when you're doing very careful pupil changes or pupil assessments that you look at the pupil with the oncoming or offgoing nurse. I'm lucky today. Anyway. Oh man. If it's not men going into my Twitchy Nurse DMs, it's people saying that I'm lucky and that I should visit them to get a GoPro or get Viewers Pro. Oh, an Olympus. Yay. Okay, back to pupil changes. Some facilities, my facility just recently got it, and it's pretty exciting, is a pupilometer. And what it is it looks like a gun, not a gun, but it looks like you hold it in your hand like a gun, and you put it against their forehead, and when you pull the trigger, it'll shine a light, and it'll measure the pupil size and pupil reactivity. And then it puts out the output of it, and then you do it with the other pupil, and it puts the output, and then it compares the two pupils. And what's really good about this tool is if you have somebody who has a brain injury and you're really checking your pupils every hour, is you can see changes as the hours go by. So, I was not a huge supporter of the pupilometer being bought for our units. But now that I've used it and I've gone to NTI and actually learned a lot more about the pupilometer, I think that it's a great thing. And if you're in a neuroscience ICU and you don't have one, you may want to talk to your managers about getting one because it can measure those changes that we can't see with our eyes and pupils. So, back to pupillary changes. Why is it important to check your pupils, especially with patients that have head injuries? Well, if you have changes in your pupils, it's a pretty good sign that something's going on in your head. So for example, here, you've got unilateral dilatation of one pupil that's fixed and non-reactive, and then the other pupil reacts and it's fine. What this means is that somewhere in the brain, there's increased pressure that's pressing on the nerves that are innervating those pupils. So if it's on one eye and not the other, it's a good chance that it's on one side of the brain. If you got it on both and they're dilated, they're fixed, and they are non-reactive, then you have some severe midbrain damage. You also may have some poisoning going on, some anticholinergic poisoning. Then here, pinpoint. These are similar. If they're normal size but they're non-reactive, you might have some brain issues in the midbrain. But the pinpoint, that can be caused by drugs, but it can also be in the pons. It could be issues going on there, either hemorrhage or a tumor. If they're pinpoint and they're not reactive, then it's an injury in the pons or it's drugs. Now, I will tell you, when they're pinpoint, it's super hard to tell if they're reactive or not. And that's where, if you work on a neuro unit or even in a trauma unit, it's a good idea to really talk to your managers about getting a pupilometer. I'm telling you, it makes assessments consistent across everybody, because my pupil assessment of 2 might be your pupil assessment of 3. So it can be very subjective, and that pupilometer takes that human side of it out. So that's very good. Okay. And then unilateral, small, non-reactive here. So this eye here is normal. This here is small, is the disruption of sympathetic nerve supply to the head, like a spinal cord lesion above the first thoracic vertebra. That's all I have on pupillary changes. So takeaway from that is make sure you do assessment with 2 nurses, like the offgoing nurse and the ongoing nurse, so that you guys know what your 2s and 3s are. Because if you get and check that patient and you didn't look at the pupils with the nurse who said it was a 2 and it looks more like a 4, well, that could have been her 2. So it's very important to do that assessment with your other nurse, especially, you don't have to do it on every patient, but patients that have a hourly check, or maybe not even an hourly check, they came in for a head injury and you have to do a pupil assessment. It's a good idea to go ahead and do that. Which brings me to a PSA, public service announcement: do bedside shift report. It's awkward, I know, because you have to talk in front of the patient and often their family members, but not only do you get their input, you also are able to verify each other's assessments so that there's more consistency. So pupilometer and bedside report. Next slide. Now we're going to talk about injuries. So we talked about where things happen. Now we're going to talk about what happens when things go wrong. And this is exciting. So we got 2 types of spinal cord injuries. We've got complete spinal cord injury, which we all kind of know what that is. That's when you've got somebody who's a paraplegic or quadriplegic, also known as tetraplegia, which is something I learned today. Tetraplegia is an inability to move arms and legs, also known as quadriplegia. And then we also have incomplete spinal cord injury. So we are going to talk about incomplete first because it has more involved in it, and then we'll finish with the complete one. We all kind of seen complete spinal cord injuries, so that's why I want to finish with that one. We'll get the hard ones out of the way first. They're not completely hard. Here's a little picture. So remember, the spinal cord is a highway. So we've got messages going down, we got messages going up, and they keep going back and forth, right? Well, in a complete one, there's a roadblock. The train tracks derailed. There's nothing there. So messages try to get down there, and it stops. Can't get down. Messages try and go up. They can't go up. They are stopped there. So there's complete breakage there. Incomplete means that there's an injury in one part of the spinal cord, but not the full cord. So sometimes messages can get down and not get back up. Sometimes messages can get up, but they can't go down. Sometimes you have a mix of the two, and we're going to talk about that. Central cord. So central cord syndrome. That's when the middle part of your cord is affected. What can cause that? When you think about central cord, you want to think muddy. Central cord syndrome is muddy. You're going to have a loss of motor skills over sensory perception. You're going to have upper extremity weakness or absent of movement. So no movement or very little movement in the upper extremities, but your legs tend to be okay. So these patients are able to stand, but they're not able to use their arms. And then you want to think distal versus proximal. So your distal extremities are going to be more effective than proximal. So they may be able to move like a little bit, but their hands, they're not able to move at all. And then E stands for an injury of extension. So extension is when your neck goes back. Whiplash, right? So central cord syndrome, think mud E. And I have pictures in case we have issues remembering. So here you go. Motor over sensory, uppers over lowers, distal over proximal, and then extension injury. So what happened, if you remember that diagram we had before, the whole gray area here is just wiped out. So these patients can still feel pain, and they have movement of the lower extremities. Okay, what does it look like on imaging? Whoa. So here, you can kind of see it. You're going to have cord compression looking thing. If you look here, it's still able to be intact. If you look here, it's still going up and down, but if you look, it's narrowed compared to the other sides of this injury here. I've had a couple patients with central cord syndrome. One actually happened because she was going to a chiropractor and probably should not have been going to a chiropractor. And she woke up, she wasn't able to move. She had some spinal cord compression. She was able to move her toes a little bit, but she was not able to move her upper extremities at all. So she had central cord syndrome. She also, the other patient I had, she had central cord syndrome from a motor vehicle accident, and she felt a lot of pain. However, she had issues with moving her upper body, and her legs she can move okay. And her problem, though, is that she had bilateral upper extremity fractures. So these patients, you can actually get up and walk them around. But with her, because she had some weakness in her lower extremities, she still had strength to stand, but she wasn't able to put pressure on her arms on a platform walker or walker that you can rest your arms on. So mobilizing her was a little difficult. But at any rate, central cord syndrome, these patients can usually walk around okay. They feel pain and temperature, and then they have very little movement or no movement in their upper extremities. Anterior cord syndrome. So anterior cord syndrome, that's when the first 2/3 of your spinal cord is affected. And this can either be from some sort of disruption with the arteries supplying that area. So that can be due to old age or an injury. And it could also be caused by trauma. The trauma for this is flexion. So when you do this, when you have an injury that your head snaps forward, and that compresses the front part of your spinal cord. Ooh. So injury to arteries. So when you have a flexion, you could disrupt some of the blood flow in that, supplying that anterior portion. You can also compress the spinal cord if you have a bad enough flexion injury. So vibrations and proprioception is good to go because that you feel on the dorsal part of your spinal cord. Keep saying column, I'm sorry. Column are the bones, cord is the nerves. But you have a loss of pain and you have a loss of temperature. So these people, if you put a hot pot in their hand, they're not going to feel it. If you pinch them, they're not going to feel it. And then you have some motor paralysis below the level of the injury. So what does that look like? By the way, I did not draw this. I robbed it from the interweb. All right, so this front part here is what's injured. So you lose your temperature and pain because that's where that's located. Your motor loss here on both sides. And then contralateral pain and temperature loss. So if your whole front end here is hurt, then you're going to have a loss, complete loss. But you're good to go because in that dorsal column, you've got your vibration, proprioception still good to go. What does this look like on imaging? It's going to look like this. If you see here, these little bulges inward on the spinal cord, that's an anterior injury there. If you can see, looks really great, right? And then all of a sudden it's compressed, 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 compressed. That's what it looks like. And there's one last one for incomplete spinal, and that is called the Brown-Séquard syndrome. And this is when half of your spinal column is injured. And this is usually due to, it's a hemicord injury, so half of your cord is injured. This is often due to a penetrating injury, like a knife to the back stabbing, a bullet through the back. I can't think of anything else. A nail gun to the back. Ugh. I'm sure it's happened. I wouldn't be surprised. It can also be due to a tumor or some sort of space-occupying lesion like a cyst. So what does this look like? What happens? Well, we're going to have ipsilateral motor. Ipsilateral means the side of the injury is going to be the side that doesn't move. And sensation loss also. Same side of the injury, you're not going to be able to move, you're not going to be able to feel anything. But you're going to have contralateral pain and temperature loss. So this side of the spinal cord controls pain and temperature on this side controls this side. Contralateral, the other side. So they'll feel pain and temperature on this side. If I got stabbed on this side I will not be able to move, but I'll feel pain and temperature, and I won't be able to feel objects. This side, I will not be able to feel, or I will not be able to move, I will not be able to feel pain or temperature, but I'll be able to move and feel things. And we'll look at a diagram. I have a diagram for this one too. So we get stabbed here. This is the back. We get stabbed here. This side, you're not going to be able to move, and you're not going to be able to feel vibration, sensation. This side, you're not going to be able to feel pain and temperature, but you'll be able to move. But you won't be able to feel, you'll be able to feel pain and temperature on this side. What does this look like? Remember, space-occupying lesion. So this here is a cyst, and if you can see, it's pressing on one side of that spinal cord. The other side is fine, but it's pressing on this side of the spinal cord. And then here is stabbing. See that? Shing. Got stabbed. Looks like a steak knife. Or no, it looks like a pocket knife. It doesn't matter. He got stabbed. And here you can see the knife part here, and it goes into the spinal cord. I'm not quite sure which side it's on, but this guy, when I Googled Brown-Séquard syndrome, this is what came up. You can see the backboard here. Put him on his stomach. Okay. Complete spinal cord injury. Here's a picture. Like I said, I didn't really put a lot on here because this is probably the easier of the two spinal cord injuries. We know that if you have a complete spinal cord injury, you're going to have some sort of either paraplegia, depending on where it's at. Like this guy, or woman, this person has paraplegia where he can't move his legs or her legs. And then if it was up higher, then it would be more complicated, because then you're having issues with your breathing because your diaphragm is here. You're having issues, you won't be able to move your arms or legs. And I've taken care of a couple patients with this. One patient was a young kid, don't drink and drive, young kid. And I remember he had a complete spinal cord injury, and I didn't know it at the time because I wasn't his main nurse, but I remember holding C-spine, and we'll talk about holding C-spine, but I remember holding his C-spine as we were transferring him over to a different bed, and he looked me in the eyes and he said, "Will I ever move again?" And I told him, "I'm not sure, I'm not your nurse," because you don't want to give false hope if there isn't hope of something happening. But it ended up that he did have a complete spinal cord injury. Now, there is science out there that, and a lot of experiments and a lot of great things coming from rehab, that I think it was a football player who had a spinal cord injury, and what they were trying to do is retrain his peripheral nerves to tell his spinal cord how to walk again. It's risky because you can't feel anything past the injury point, but sometimes that's life-changing. You know, if you're able to have some sort of leg brace or something and you're able to walk again, that is life-changing. I can't remember if this other patient had a complete spinal cord injury or an incomplete, but we had a patient that was out on the lake with friends, and he was goofing around and he dove into the lake, and there just happened to be a log or a rock where he dove into the lake, and he was injured immediately. Sorry. Hey. Sorry, that was my dog. Okay, so anyway, back to this guy. He dove into the lake. He had a spinal cord injury, and he had issues walking and moving his arms after that injury. And it was, sorry. He didn't give up after that injury. He really actually worked very hard, and he is now able to use his arms, and he has put together a foundation. It's called Ed Strong. If you want to check out his website, it's edstrong.org. And he has a facility all his family and friends raised money to put this facility together. They brought in special trainers and physical therapists, and they work with people with spinal cord injuries to help them strengthen, to help gain more mobility. So they try and help them to reach the highest level of mobility that they can and empower them to do things that maybe they did before, but are having a little more difficulty doing now. And there's a lot of special equipment out there that can keep your quality of life high even though you have really bad spinal cord injuries. He has gone on skiing trips, he's put together races, and he has, a racing wheelchair and special skis so that he's able to do and still live life. So spinal cord injuries are not the end of life. It's very frustrating and it can be very emotional, and it's very important as nurses to be an emotional support for the family and the patient. But there's a lot out there that can help them have a very high quality of life. Okay. It's mainly caused by trauma and compression injuries, spinal column fractures. All right, so what do we do with these injuries? Well, whenever you move the patient, it's very, very important that you hold alignment of the spine. You're going to, when you move them up in bed, someone is going to hold C-spine if they have a cervical spinal injury. If you need to roll them, you're going to do a log roll, where I have pictures too. But you keep the spine in alignment as you roll the patient over. So everything is in alignment as you're moving this patient. You're going to have a C-collar on most of these patients. And C-collar, it doesn't always need to be because you have a spinal cord injury. A lot of times an injury may not have affected the spinal cord, but it has affected and damaged the ligaments in the neck. And that, if you don't have a C-collar, that can actually cause further issues for your spinal cord. So a lot of times you'll have patients who have a spinal cord injury and a C-collar. Pressure injuries. This is very important because remember, some of these people cannot feel. So it's very important that you teach them to do very thorough skin assessments, and that you as the nurse do very thorough skin assessments. Check everywhere. All the bony prominences, the backside, your hips, your heels, your elbows, any areas can cause, or any areas can develop a pressure injury. If you have devices such as a C-collar, and we'll talk about different collars, there's halo vests and everything, you want to check under those pads. You want to check out under those devices to make sure that you don't have any pressure injury. Some people, this is doctor to doctor, but some people for spinal cord injuries, they'll have permissive hypertension, and that keeps the blood flowing to that area and it helps promote healing. Physical therapy. Just because your patient has a complete spinal cord injury, that does not mean that they don't need physical therapy. You want to get physical therapy on board as quickly as possible, because that is what's going to help empower that person. A person who may be a paraplegic is still able to pull themselves over to chairs. And if they're able to recognize that strength and you help them with that, it is psychologically beneficial to that patient. So don't forget to get physical therapy on board as soon as possible and learn from them. They are a wealth of knowledge, and I've learned so much from physical therapists on moving my patients with multiple different types of injuries. And then also, we're going to probably prepare these patients for surgery. Some spinal cord injuries are non-operable, but for the most part, some of them will get surgery to fix that spinal column so the spinal cord can heal a little bit better. So this here is there's a couple different kinds of collars. Cervical collars. And I'm just going to show pictures of the two that you will see people use the most. And there's a study out there that measured the two, and it's a lot of, one has more benefits than the other, and the other one has more benefits than that one. So they did a study on how patients are able to move in these collars. like how much movement do they allow. It's an interesting study. If you Google what's the difference between Aspen and Miami J, you'll see that. But this here is an Aspen collar, and these pads are removable here, and you put them back. And when you have a patient that's a trauma that's really bloody, you want to be changing their pads. You want to make sure that they stay dry. It's really important for the condition of the skin under the collar. This here is a Miami J. So like I said, there is a study out there that compares these two and one other collar, I think a soft collar. These pads are also removable, but a lot of times if you work in a facility, the Aspen collar will come with extra pads, and this you have to kind of order extra pads. These can be disposable or you can wash them out. This has more of a silky feel to it, and it can be harder to get a hold of, so when you wash these, make sure you have an extra set. Okay, this is Gardner Wells tongs, this right here, and this patient is in cervical traction. So if you can see here, they drill into the bone to the skull, and they attach the Gardner Wells tongs, and then they have a string coming off, and then it's to weights. So in this bag, there's weights in there, and they do calculation according to the patient's body weight, and then they attach this. These patients cannot really raise their head. You shouldn't raise their head. You can put them in reverse Trendelenburg, but these people have to lay on their back and sometimes you might be able to do micro turns, like itty bitty turns to keep pressure off. But for the most part, these patients are going to be in this. We don't like to keep patients in this long, so we like to send them to surgery or get a halo vest on as soon as possible. This is very uncomfortable to be in, by the way. I've never been in it, but my patients always talk about it. This is a halo vest. So this goes on the torso, and then these are like rebar, really heavy duty bars. They drill into the head at pin sites here and in the back. And then the patient is unable to turn their head or move it up or back. So this is called a halo vest because it puts your head in a halo. If you're a little bit older, you might remember that Regina had a halo vest in Mean Girls because she was hit by a bus. This is not really, a halo vest does not really have, it doesn't go down to your waist. For women, they have cutouts here, like you can see here. And then this would have gone into her chest piece, but doesn't make for good movies because you can't show off the dress. So, but anyway, if you saw this movie, that's what she had. She had a halo vest on, halo waist vest. All right, cervical immobilization. So when you're turning these patients, if you are removing the collar for whatever reason, whether you need to change the pads, you're assessing the skin, you need to hold cervical immobilization. So hold C-spine. And if you can see, they're doing a very firm hold on this guy's cheek. You can see their thumbs indenting his cheek. You got to firmly hold their head so that they do not move. And then you're immobilizing the back of the spine here. And then when you have the C-collar on, you're still going to immobilize until it's secure. And then whenever you're turning this patient, you're still going to hold C-spine. You're still going to immobilize the neck. What is log rolling? Log rolling is when you roll and you keep that spinal column in alignment. So you got someone holding C-spine, you've got two people, and you cross your arms. So someone is holding the hips down past the butt cheek, someone's holding the hips above the butt cheek, and then you got the shoulder and the legs. And when you turn synchronized. And the person who is doing C-spine is the counter. So on the count of 3, they go 1, 2, 3, and then you roll one way. When you lay back 1, 2, 3, you roll on your back. Everything has to be in alignment, so you have to do a countdown to do your log roll. All right, we're almost done. Spinal surgeries. So this is another thing that you're going to see in all areas of nursing, because when I worked on the med-surg unit, I saw people who had ACDFs, or an anterior approach to their surgery. You'll see patients in units when they've had spinal fusions. So wherever you work, you're going to see people who have spinal surgeries, ICU, acute care, even in the clinics and rehab areas. So what are some surgeries? We've got fusions. That's where they take the spinal column and they either remove the disc, or it's a compression fracture and they have to pretty much like glue the spinal column together. So those patients who have osteoporosis and have compression injuries from that, they'll kind of not glue, but they'll cement the spinal column together. Then there's also metal, I'll show you in a moment. But fusion means that there's no more movement in that area where the fusion is. There's no more movement like this or this, there's nothing. So patients who have a traumatic injury, they're not going to be able to move the way they used to. We've got laminectomies. That is when there is a narrowing of the actual passage of where the cord goes through. And what they do there is they go ahead and they scrape out some of the bony area there, and then that opens up that space so that spinal cord is not compressed. And then we've got discectomies. That's when they remove the full disc. So in between each of your vertebrae, you've got a disc. They'll remove that whole disc. And most of the time, they'll do this with laminectomies. And then when they remove the disc, they'll either put an artificial one in or they'll just fuse the spine. And then foraminectomies. So what that is when, if you look at the spinal column and the spinal cord together, so you've got the spinal cord going through each of the vertebrae, right? And then on the back end, you've got the nerves coming out. Well, sometimes where that nerve is coming out, you're going to have narrowing. So what they do is they go in and they increase that opening so the nerve coming out the back has more space. So what do we do for patients with spinal surgeries? Well, you're going to assess pain. You're also going to assess your sensation, your motor function, how strong they are. And this is another thing that you need to do a bedside report on so that you guys can test the patient's neural function together, because that patient may be weak to me, but to the oncoming nurse it might be a moderate. It's very subjective. So make sure you do your neural function tests with the oncoming or offgoing nurse, whichever shift you're on. You want to assess feeling, so that's when you start assessing those dermatomes, right? Make sure that they have feeling past below that injury and then above that injury or surgical site. So this is a spinal fusion, and you can see here they screw into the spinal column and then it looks like that. So this is a fusion. So this person is going to be unable to move. This is basically rods in their back. They will be unable to move in that area. This is a discectomy. So here you've got a vertebrae. This is an anterior approach. They removed this disc already, and then here they're removing the disc. I couldn't find a good surgical picture for it. And then I couldn't find a good surgical picture for the foraminectomy. I don't pronounce these words right. Foraminotomy. So here you can see the disc is pushing that bone out. So what they do is they go ahead and they cut this down on this side, they fix the disc rupture, and that causes the spinal nerve to have more freedom, so it looks open and pretty like this one. All right, question time. And this is an NCLEX question. A client with a spinal cord injury is prone to experience, I don't like when they use client. A patient with a spinal cord injury is prone to experiencing autonomic dysreflexia. The nurse would include which measures in the plan of care to minimize the risk of occurrence of what? Select all that apply. Keeping the linens wrinkle-free under the client. Preventing unnecessary pressure on the lower limbs. Limiting bladder catheterization to once every 12 hours. Turning and repositioning the client at least every 2 hours. Ensuring that the client has a bowel movement at least once a week. So the question is, a client with a spinal cord injury is prone to experiencing autonomic dysreflexia. The nurse would include which measures in the plan of care to minimize the risk of occurrence of what? So what is autonomic dysreflexia? Well, let's break down this word. Autonomic. Where have we seen that before? The autonomic nervous system, right? The sympathetic, parasympathetic. Dysreflexia. Dys is a negative. It means something's not right. So something is not right with this person's autonomic nervous system. So let's see. We've got keywords here, right? We've got keywords. We've got spinal cord injury. We have autonomic dysreflexia. Okay, and we want to minimize the risk. So those are our keywords. So, keeping the linens wrinkle-free under the client. That makes sense, right? Because remember what I said about spinal cord injuries. These patients are prone to pressure injuries because a lot of them are unable to feel pain, or they're unable to feel different sensations. So I would say A would be a good option. And remember, we're selecting all that applies. So A might be the only answer, but for all intents and purposes, there's probably more. Very rarely do I see that only one answer is picked when it's a select all that apply. So A is a big contender. Preventing unnecessary pressure on the lower limbs. That's probably a contender too, right? Because here's another pressure. We don't want to put pressure on this patient. They're more prone to pressure injuries. So B sounds like a good contender. Limiting bladder catheterization to once every 12 hours. So autonomic dysreflexia, let's think about that. Remember that these patients, if their autonomic nervous system is not working well, that means they could have urinary retention because our bladder tone is super relaxed and our sphincters are closed up. And so these patients tend to hold on to their urine and their poop, for that matter. So once every 12 hours, I don't know. I mean, I've held my bladder for 12 hours, but it's mostly because I haven't been drinking. But it's super uncomfortable. I don't know if any of you have tried to not pee for 12 hours, but it's super uncomfortable. And remember, when urine is sitting in the bladder for a while, that's an increased risk for infection. So we're probably going to want to drain this person's bladder more than every 12 hours, right? So I would say C is not a good contender. So let's cross C out. Turning and repositioning the client at least every 2 hours. So when you turn and reposition the patient, you take pressure off of areas that pressure was on for 2 hours. So, at least every 2 hours, that's a good time frame. And usually facilities do have policies to turn and reposition patients every 2 hours. My facility does. So turning and repositioning the client at least every 2 hours, that's going to help prevent pressure injuries. I would say that's a contender. And then ensuring that the client has bowel movements at least once a week. Again, these patients that have issues with their autonomic nervous system, we need to make sure that they are having regular bowel movements. Once a week is not really regular. You want to go at least every day, every other day, so you want to make sure that they're going more than once a week. So I would say E is out. So if you were doing this with me and you say A, B, and D, you would be correct. Great job. You can now pass the NCLEX. Okay. This is also an NCLEX question. The nurse has completed discharge instructions for a client with an application of a halo device who sustained a cervical spinal cord injury. Which statement indicates that the client needs further clarification of the instructions? I will use a straw for drinking. I will drive only during the daytime. I will be careful because the device alters balance. I will wash the skin daily under the lamb's wool liner of the vest. The vest has lamb's wool liner. Okay, so, which one is that? Let's read the question again. The nurse has completed discharge instructions for a client with the application of a halo device. So here we have halo device, who sustained a cervical spinal cord injury. Which statement indicates that the client needs further clarification? So this means we're looking for what? We're looking for a wrong answer. The patient is going to tell us something that we're like, that's not what I said. So we need to provide the client with further explanation. Let's read the answers again. I will use a straw for drinking. If you remember, the halo vest is attached to their skull like this, and it's got big rods going down to their vest, right? So they can't really move this way or this way. So they're stuck like this. So using a straw for drinking, I would say that's a good one, right? We'll put a smiley face. A really janky smiley face. Creepy one, because it's in red and it's a creepy looking one. I will drive only during the daytime. Remember, we've got this halo vest that they can't really move their head back and forth. So should they be driving at all? Probably not. They should not be driving, because then they'll end up in the hospital with an even worse injury and maybe somebody else. So B is a contender. Let's read on. I will be careful because the device alters balance. Well, if you saw that thing, it looks pretty clunky. So I would say that's a good answer. And also, when you get up from a sitting position or laying down position, and I don't know how someone would be able to lay flat with this, but it's you move a lot more than what you think you do. So this device can alter balance if you're not able to move like you normally do. So this one is also a contender. That's a little less creepy. Still in red, it's creepy. I will wash the skin daily under the lamb's wool liner of the vest. Remember, as a nurse, it is important to check the skin. You want to make sure that it's clean and dry, right? So this is a good answer because we want the patient to daily look at their skin to make sure that there is no device-related pressure injury under that vest. So I would say this is a good one. This may seem like a really obvious answer, but anyone who's in a halo device should not be driving. That is a danger to themselves and to others. They're not able to react quickly. They're not able to turn their head to look, to check blind spots, check their surroundings, because they have to move their whole upper body to look around. That's not safe. All right, did you pick B? Good job. All right, this next one is a CCRN question. It's kind of easy, but I picked this one so I can tell you how to remember it. Which of the following correctly identifies the number of vertebrae in each segment of the vertebral column? 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 3. Oh, I'm missing this one. I think this is 7 cervical. I think the question said 7 cervical, 12 thoracic, 7 lumbar, 6 sacral, and 2. And the last one I think was again 8 cervical, 11 thoracic, 5 lumbar, 4 sacral, and 5 coccygeal. Coccygeal. Okay. Which of the following correctly identifies the number of vertebrae in each segment of the vertebral column? So, you've got these 5 sections: the cervical, the thoracic, the lumbar, the sacral, and the coccygeal. And these are usually fused. Okay. Here's an easy way to remember it. Here's a spinal column. Okay. You have 7 cervical, 7 a.m. morning time. 12 thoracic for 12 noon. 5 p.m., 5 lumbar. And then there is 5 sacral, 5 lumbar, 5 sacral, and then 4. So match and take away 1. So 7, 12, 5, 5, 4. So the answer is A. If you remember the times a day, you'll be able to get this question. All right, another CCRN. One day, following posterior spinal fusion surgery, a 35-year-old female suddenly exhibits restlessness, labored breathing, and acute chest pain. Her heart rate is 122 beats per minute. She is afebrile and exhibits slightly diminished breath sounds on the right side. The findings described above should lead the nurse to suspect that the patient has developed a spontaneous pneumothorax, a pulmonary embolus, aspiration pneumonia, a pleural effusion. So, if you noticed, this is not actually a spinal question. However, you have to think about post-surgical complications, and that's why I threw this one in here. So, we have an increased heart rate. We have a patient who is post-op, posterior spinal fusion. Does that matter? Not really for this question. We just need to know that this patient is post-op. And that, in and of itself, has a lot of complications, right? So, she's restless, she has labored breathing, and acute chest pain. Acute chest pain. Her heart rate is elevated, she is afebrile, and she has slightly diminished breaths on the right side. So which is this? What is this describing? Spontaneous pneumothorax. What are symptoms of that? Well, you may have diminished breath sounds or absent breath sounds. You're not really going to have an elevated heart rate. You are going to have acute chest pain, but not necessarily restlessness. So I would say A is out. Pulmonary embolus. That's going to cause acute chest pain. You're going to have labored breathing. You're going to have diminished breath sounds. You won't have a fever, and you'll be restless because pulmonary embolus is a blockage in the vessels in the lungs, and so you're not able to get enough oxygen, so you start to get really restless. So B is a good contender, but let's move on. Aspiration pneumonia. Well, pneumonia is an infection, right? So you won't be afebrile, so we could take away C. And a pleural effusion. Effusion can also, it is liquid in the pleural space. you're not going to have an elevated heart rate, and you may have a fever or you may not have a fever, and you're not really going to have labored breathing or restlessness because you still have full function of your lungs. So D would not be it either. The answer is B. So if you picked B, good job. Okay. Now we've got just 2 TCRN questions, and then we're good for the week. A patient has a stable C4 fracture, so the 4th cervical vertebrae. Treatment involves wearing a cervical collar for 8 weeks. Which of the following patient statements indicates adequate understanding of discharge instructions? So this means that the patient, we don't need to do any further treatment past what we did because they understand what's going on. I will take the collar off for no more than 1 hour each day. I will wear the cervical collar whenever I am out of bed. I will remove the collar and splint my head with pillows at night. I will check for skin breakdown beneath my collar every day. Patient has a stable C4 fracture. Treatment involves wearing a cervical collar for 8 weeks. Which of the following patient statements indicates an adequate understanding of discharge instructions? What do you remember about talking about C-collars? Can you take that C-collar off? The only way you can take a C-collar off is if the spinal or the cervical spine is immobilized, either manually or with a C-collar. So that would say that the patient does not understand what's going on, and I would say we would need to explain things more. So I would say A is out. I will wear the cervical collar whenever I'm out of bed. Now, we can take from this statement that if they go to bed, they're going to take it off. And they need to wear that cervical collar all the time, unless they're immobilized some other way. So, B is out. I will remove, well, right there, remove the collar. We already know this is wrong, right? But let's read on. I will remove the collar and splint my head with pillows at night. I don't know about you, but I know that I tend to move around a lot at night. So if I removed a C collar, I would probably paralyze myself if I had a C4 spinal fracture. So C is out. I will check for skin breakdown beneath my collar every day. Remember, we want to check the skin condition of the skin under these collars. Make sure it's still clean and dry. Make sure that that collar is not pressing in and causing pressure injuries, right? So we want our patients to do that when they go home. So if you pick D, good job. You got it right. Last one. This is a TCRN question as well. A patient acquired an incomplete C7 spinal cord injury in a driving incident 3 days ago. Current vital signs are 88/48, 43 beats per minute heart rate, SpO2 of 98% on 3 liters nasal cannula, and respiratory rate of 18 breaths per minute, which are shallow and unassisted, so they're breathing on their own. Which of the following medications is contraindicated in this patient? Nitroprusside, dopamine, norepinephrine, dobutamine, or dobutamine. Okay, so this is nitro, right? Dopamine is dopamine. Norepinephrine, that's also called Levofed. So sometimes you'll hear the word Levo. And dobutamine, sometimes you'll hear people call it dobutamine. So all these are medications that affect blood pressure, right? This is a pharmacology one. So all these medications affect blood pressure, which we need. We need something to work, right? Because his blood pressure is pretty low, and people who have spinal cord injuries, we want to keep their blood pressure up. We want blood flow to that injured area. So what does nitro do to your blood pressure? Well, it lowers it, right? Because what is nitro? Nitro is a vasodilator. It takes those blood vessels and it dilates it out. A lot of times when a patient has a heart attack, those vessels, we need to dilate them. We need the blood supply to get to that heart. We need to save as much muscle of the heart we can. So we give them nitro to help open up those blood vessels and get blood to those damaged areas of the heart. Dopamine will increase your blood pressure. It can also increase your heart rate, which this patient doesn't necessarily need, but if he's a healthy guy or girl, but a lot of times our spinal patients, we could use a little help with the heart rate. So dopamine would help with the blood pressure and the heart rate. Norepinephrine or levo, that's a vasoconstrictor, and it helps the heart beat a little bit. So that's going to make our blood pressure go up. And dobutamine, that is an inotrope, so it doesn't really affect blood pressure. It helps the heart beat faster, but it doesn't mean that we can't use it in this patient. It's not contraindicated. Remember, we're looking for which medication can we not use. So which medication would you not want to use? Well, I certainly wouldn't want to give them something that causes their blood pressure to go down, right? Because we're already low enough. So if you guessed A, or you thought about A, then you are correct. And that's it, folks. That's the end of today's study session. I hope you learned something. I know for me, neurology and neuro injuries is not my forte. So for me, I did learn it was good to review these things, especially the spinal cord injuries. That was a lot of help for me to review over that. And then it was helpful to be able to see some of the surgeries and see what my patients are experiencing with that. So I hope you learned along with me, and I really do hope that you guys like, subscribe, hit that heart on Twitch so that you can keep up to date with everything that's going on with Twitchy Nurse, and then send in some study things. Let's get this really interactive, guys. And I will see you right here next week, Tuesday, 8 p.m. I'll see you later. Bye-bye.